My name is Bede Moloney, and this is my second clinical reflection for my paramedic clinical practice. We were called to a 64-year-old male complaining of crushing central chest pain with a history of angina, code 1. When we got there, we found him slouched over a table with one hand on his forehead and the other hand clutching his chest, Levine's position if you want to get fancy. He also looked sick, which is a phrase that I've heard from other paramedics but hadn't really witnessed or understood until I saw this guy. He was pale, he was sweaty, he was grimacing, clearly in a lot of pain. He just looked sick. He said he'd been gardening and the pain had come on, so he sat down and had a spray of GTN, which usually relieves pains of this kind. He's had them for a while, but this time it was worse than usual and it wasn't relieved. It turned out after transport and medical imaging, I checked up on him later, that he'd graduated from stable angina to unstable. Now, I'd never been to a STEMI or a non-STEMI before, but my tutors have been educating me comprehensively, some might say relentlessly, on the subject, the physiology of the heart and the procedures for reversal and buying time to hospital. So every part of this patient's sample was adding up to some kind of myocardial infarction for me. The pain, the medication he was on, his past medical history, even the events leading up to it, they were all indicating some kind of acute coronary syndrome. Which is why it was strange that the patient's GTN had no effect. Not eliminating the pain I can understand, but no effect at all. He wasn't diabetic, he wasn't elderly, so a silent heart attack is largely out of the question. And a 12 lead showed no sign of ischemic changes or ST elevations of any kind. So we gave him aspirin, we witnessed him taking another spray of GTN, and we got him on the ambulance as quickly as we could. Man had about 15 cats to dodge on the way. With no developing symptoms and a stable patient, really had no recourse other than to treat and transport according to the presenting condition. So already feeling lit up in my depth, I was basically handed a person in distress and given the patient management seat. Willis and Dalrymple's Fundamentals of Paramedic Practice have a lot to say about how one of the most important aspects of pre-hospital cardiac management is to keep the patient calm. Elevated heartbeat isn't going to help you if your heart's not getting enough oxygen. Well, that went out the window when he started talking about how all the things he hadn't accomplished in life yet. So to keep him distracted, we set about getting a comprehensive history from him, including his current medications, and lo and behold, his GTN had expired in 2012. Now, the QAS Clinical Handbook is very diligent in reminding us of correct drug checking procedure, but I think reminding the public would be a good way to go as well. All told, there was probably 7 to 10 minutes between our arrival, realizing he was under-medicated and correcting it, but had this situation been any different, it could have gone much, much worse. Ultimately, his chest pain lowered, the use of in-date GTN, aspirin, and the full 100 mics of fentanyl by the time we got to hospital, his vital signs were entirely within normal limits, and his chest pain was 2 out of 10. What I learned was this: check patient medications. Find an acceptable answer to the am I going to die question, which I haven't done yet, but we'll give it some more thought. And just because it looks like a non-STEMI and acts like a non-STEMI doesn't mean it's a non-STEMI. Ultimately, the 6 weeks have been an incredibly positive educational experience, and I very much look forward to my next experience en route. Thank you very much.